Hello, everyone. Thank you so much for joining us for our very first MBC Impact Series event of 2024. My name is Casey Volpe, and I work with Komen's Community Education and Outreach team. I have the distinct pleasure of running this program. If you're here today and you're new and you haven't attended one before, I just want to make sure this program is monthly. We do different topics every month, and it's envisioned as a year-long conversation with attendees where we present new information, new speakers every month. So stay in touch and join us whenever the topic is of interest. Today, we're going to kick off the year starting with research on metastatic ER-positive breast cancer, and our featured speaker is Dr. Pejam Razavi with Memorial Sloan Kettering. I apologize for the stuttering. I have a cough drop in my mouth because it's either that or coughing through this, so bear with me. Diving into some housekeeping before we get started, before we begin, Komen would like to thank our sponsors for supporting the 2023 MBC Impact Series. So thank you to our premier sponsors, AstraZeneca, Gilead, GE Healthcare, and Merck, and our signature sponsors, Walgreens and Daiichi Sankyo. Their generosity is why we're able to bring this programming to you month in and month out all year long. So one more note, while our speaker is presenting, feel free to post your questions in the Q&A feature in Zoom, and we'll get to as many as we can. I do want to emphasize we'll get to as many as we can. We have a very big group today, and I'm so grateful for you guys signing in. I'm sure you're just as excited to get to the presentation as I am. If we do run out of time, I apologize now in advance that we weren't able to get to your question. We will do our best. When you log in, when you open the Q&A, you should be able to see questions that have also already been asked. And so if you happen to see a question that's very similar or the same as yours, that's further up, then maybe just try and wait. And that'll help us kind of dig through all of it and try to get through as many topics as possible. Towards the end of the programming, we're going to put a survey in the link, or a survey link in the chat. So that you can give us some feedback on how we did today, what you'd like to see out of the programming for the rest of the year. I personally look at these, so I promise you they don't go into the virtual abyss. They're really, really helpful. So please take just a few seconds. It's only a few questions, and it would mean the world to me. All right, now, I'm very excited to get us started. I want to leave us plenty of time for the presentation and all the Q&A we can fit in. So to start, I'm going to introduce you to our moderator, Anne-Marie Mercurio. Anne-Marie was successfully treated in 2006-2007 for lobular breast cancer and stepped into advocacy about 3 years later when she realized she was suffering with ongoing cognitive issues. Her attempt to enroll in a clinical trial was initially unsuccessful, but her persistence in seeking an evaluation would soon result in the investigator requesting an amendment to the protocol. She was her late mom's primary caregiver when she was diagnosed with early-stage breast cancer for the second time in 2007, followed by a diagnosis of metastatic disease in 2013. Anne-Marie has served on several grant review panels and has had the privilege of serving as the patient advocate on several funded grants. She is currently the chair of Patient Insights Board at Meditata and the co-chair of the Patient Advocate Committee at SWOG Cancer Research Network. I apologize for butchering so much of this introduction. Anne-Marie, the floor is yours. They don't have to listen to me anymore.
Thank you. Thanks so very much, Casey. It is really wonderful to be here today. This is a topic that's near and dear to my heart. As Casey shared, I was quote unquote successfully treated for ER positive breast cancer back in 2006-07. But I watched my mom on a similar path with 2 separate primaries at 30-year intervals. And then had her disease metastasize 6 years after the second primary. She was treated at Memorial, where Dr. Razavi, I'm going to butcher your name, Dr. Razavi practices. She received excellent care there, and she survived until she was 83 years old. So that is a little note of hopefulness for everyone. There is so much progress being made in this, but we all are aware that, ER positive disease tends to, pop up later. So with that, I want to introduce, and I would like someone to pop up Dr. Razavi's slide so that we can get all his credentials out there. I'm just going to do what Casey did, and I'm just going to read it. Dr. Razavi is a medical oncologist and a physician scientist focusing on precision oncology in breast cancer. He leads MSK's Breast Molecular Tumor Board and Translational Platform and is the director of liquid biopsy and genomics in the biomarker development program. His research concentrates on clinicogenomics and circulating tumor biomarkers to guide translational breast cancer research. That's all a lot of really big words to say. He's looking at the latest and greatest of what is going to be able to more easily guide treatment. We're going to look at the blood rather than having to biopsy tumors all the time. And this is going to be the next great thing. I am sorry for editorializing your bio here. But I think we're all interested in, knowing, okay, so he earned his medical degree from Tehran University and an MPH and PhD in cancer epidemiology at USC, followed by a postdoctoral fellowship at the Channing Laboratory in Boston, an internal medicine residency at USC, medical oncology fellowship at MSK, worked in the laboratory of Dr. Baselga, who I have such fondness in my heart for, and joined the faculty at MSK in 2016. Dr. Razavi, please come on screen and take it away with all of the really cool science that you're doing.
I cannot.
Get your video to work. Now that's
Yeah,
a
so you can
problem.
start your video because the host has stopped it. So maybe, yes, perfect.
Okay.
Fantastic, fantastic. Thanks
So
so much for the kind
welcome.
invitation and kind introduction. Truly a pleasure to be here and present some of the work that we've been doing at MSK, where we think the field is going, and share some of the data and scientific work that has been happening in our group. Without further ado, I'm just going to start going through the presentation, looking forward to the questions and the discussion. Thanks so much. All right, so let me just share. Perfect.
Beautiful.
So I'm going to talk exactly what was in the introduction. I'm going to talk about how we use the clinical and genomic data to understand ER-positive metastatic breast cancer better and solve some of the difficult questions that we have in biology of breast cancer and how to move forward. So these are my disclosures. So precision oncology and targeted therapy is not a new concept in breast cancer. It goes back to 1800s, late 1800s, when they identified the link between ovaries and progression of locally advanced breast cancer. It was suggested that if you remove the ovaries, breast cancer is going to regress. And actually, this was the first example of targeted therapies that happened with the oophorectomy and removing the ovaries, resulting in regression of the disease. And the field of precision oncology obviously has completely changed and transformed in the past few years. So we look at the different targets. We identify a subgroup of patients who respond to certain therapies. We put them on the therapy, and then we monitor them very closely with liquid biopsy. We get biopsies before and after treatment. We use functional imaging and functional genomics. And also on the side, here we also try to understand from every single patient, get as many samples and research samples as possible, something that we have pioneered here at MSK, and other cancer centers and major academic centers are also doing, try to make xenografts, animal models, cell lines from the patient samples, understand why some of them respond, why some of them do not respond, and improve everything for the next round and the next line of treatment for the other patients who would benefit from this. So at MSK since 2013, we've been using MSK Impact, which is our tumor sequencing panel, and more recently is MSK Access, which is our liquid biopsy assay. I wanted this to be 10,000 breast tumors by today, but we didn't reach it. We just 653 patient tumors, maybe by tomorrow short, we get to 10,000, which is a big achievement for us. We have sequenced now close to 10,000 breast tumors from more than 7,500 patients. And this data is internally anonymized and available to MSK researchers and community to better understand the data, the biology of the tumor, and also use it to advance science. But when we are looking at the precision oncology, and these are the early days of precision oncology, I'm showing this very young woman with this secretory breast carcinoma. These are the type of cancers that are completely resistant to chemotherapy, to radiation therapy, so on and so forth. But they have a Achilles, and that's the TRK fusions or NTRK genes fusions. And when the TRK inhibitors were invented, this is the first patient who went on the trial, and you see such a response, dramatic response to the targeted therapy. Unfortunately, for bread and butter breast cancers, the breast cancer proven to be much more complex than these secretory breast cancers, and it's much smaller and much more heterogeneous. And that resulted in the fact that, we started to understand that other than knowing the target and having a targeted therapy for the patient, there is many other features that can affect the outcomes of the patients. The patients can have alterations in the genes that are less commonly mutated in breast cancer or involved in breast cancer, or they have rare variants in a gene that is known to be a driver in breast cancer, but we didn't know about that particular mutation. And also, more importantly, there is a huge amount of crosstalk and interaction between the genomic alterations in the patients, and also there is heterogeneity, both spatial heterogeneity, meaning different sites of cancer having different genomic profile, and also temporal heterogeneity, meaning that breast cancer evolves throughout time. So all of that resulted in a complexity in understanding and utilizing the precision oncology in breast cancer. So we started our real-world clinical genomic program in 2014, and the idea was, now that we are using this clinical sequencing in clinic, can we also use this information to decipher breast cancer better and understand the biology of breast cancer better? For that, we put together a large database, anonymized database with the full clinical data. Also, we added pathology data, laboratory data, more recently, imaging and raw imaging from radiology, from digital pathology, all of that combined in a database. And when we developed analytical pipelines and validated these analytical pipelines to understand the biology better. So we have the genomic data, and then we have the clinical data and other aspects of the data from each patient going into the clinical genomic analytical pipelines. And our main question was, can we understand the biology better? Can we understand mechanisms of response and resistance? Can we identify a subgroup of patients who do really well and a group of patients who unfortunately don't do very well from the very beginning when we see the patient? So with that, the first thing that we tackled was obviously endocrine therapy and metastatic disease. So when we started this work, the landscape and the genomic landscape of metastatic breast cancer was very much unknown. A lot of analyses were done, and we knew about a lot of genes and the drivers in the primary breast tumors. But in metastatic disease, that was more of a mystery at the time when we started this. There was some small case series reported. So it was the largest study of its kind, utilizing the samples that we sequenced in clinic, showing that there was an enrichment of multiple genes in the metastatic patients, some of them associated with metastatic recurrence and metastatic sites, some of them associated with response or resistance to therapy. And the highlight of it, obviously, a gene that many of you guys are familiar with is the ESR1 mutation, that for which we now have a approved drug, and it's a major mechanism of resistance to endocrine therapy in ER-positive breast cancer. But we also, in ER-positive breast cancer, we found many genes that were significantly enriched in metastatic tumors when we compared to the treatment-naive primary tumors. This is a data. The bar plots on the left side shows the frequency of these alterations in genes in the metastatic endocrine resistant tumors compared to the treatment naive primary tumors. And you see that there was a very significant difference. Multiple genes were significantly enriched. And then we looked at them, we were able to categorize them into three main categories. Obviously, the ESR1 mutation is a known mechanism of resistance, but we also found that genes in a signaling pathway called MAPK, with multiple genes included in the MAPK pathway, were enriched in the endocrine-resistant tumors. We also found multiple transcription factors. These are the genes that regulate the expression of the genes, also were enriched. And then more importantly, what I show you here is what we call an oncoprint. So each patient or each tumor is in the column, and the genes are in the rows. And you see that there was a complete mutual exclusivity of ESR1, which is a known mechanism of resistance to endocrine therapy, and these MAPK alterations and transcription factors, even transcription factors and MAPK alterations, were mutually exclusive with each other. That told us that these tumors don't need to have ESR1 mutation, meaning that potentially these alterations result in endocrine resistance as well. And then what I don't show here is that we did a multiple series of experiments, showed both in the clinical samples and also in the preclinical series that indeed the MAPK alterations and also the transcription factors result in endocrine resistance. We have multiple papers in the follow-up that shows that actually the mechanism of resistance by each one of these, and we have multiple ongoing work trying to understand the biology for each one of these transcription factors and also the alterations in MAPK, which one of them, how they result in resistance, how we tackle them in clinical trials. Happy to say that we had a clinical trial actually designed based on this data for the patients who had MAPK alterations and had endocrine-resistant tumor. But what is important based on this work was that we still, after such comprehensive analysis, we still didn't know the mechanism of resistance probably around 60% of the patients. This gap has been closed since then, but still a substantial number of patients who did not understand the mechanism of resistance by doing genomic analysis alone. So for that, we expanded this analysis, and now we are doing one of the largest study of its kind. We are doing the paired analysis of the primary tumors and metastatic samples in patients with ER-positive disease who received endocrine therapy. And also we match them with similar patients diagnosed at the same time, same stage, diagnosed, but they never had metastatic disease and received endocrine therapy. The idea here is to understand the differences in the tumor biology and tumor genomics in the primary tumor, and also match the metastatic disease and the primary disease to see what are the mechanisms, and more importantly, can we predict what tumor is capable of and which tumor is capable of developing which mechanism of resistance. And that can be extremely helpful for us, put us ahead of the tumor. Before the tumor develops a mechanism of resistance, can we understand what this tumor is capable of and then try to block that mechanism of resistance? So that's the goal of this study. It's accruing very well, and we have been able to analyze some of the samples. So hopefully in some of the upcoming conferences, we will report some of this data. So obviously, as many of you know, and you've received these treatments, endocrine therapy alone is hardly used in breast cancer at this point. And the standard of care is the combination of CDK4/6 inhibitors and anti-estrogens, either AIs, aromatase inhibitors, or fulvestrant or other SERDs. So we focused on the next part of our analysis on the CDK4/6 resistance, something that was completely unknown. And then we had two focuses. So the first focus was, who are those patients, 10, 15%, 20% of the patients who do not respond as well to the CDK4/6 inhibitors? There's a group of patients who do extremely well. Majority of the patients make it to 2 years and above. The median progression-free survival in this group is 2 years. But there is a group of patients who do not respond to the CDK4/6 inhibitors. So we wanted to understand who are these patients. So we put together an analysis of what I'm showing here is called the volcano plot. So the more to the right, the more the gene is associated with resistance, and the higher the y-axis is the significance, the more significant p-value here. So what we found was that RB1, this is a gene, very important biology. of CDK4/6 inhibitors. It's on downstream of CDK4/6 inhibition and results in resistance to CDK4/6 inhibitors by removing the target. So the cells become completely independent of CDK4/6 inhibitors. So we found RB1 for the first time in this large case series, clinical case series, to be associated. It's been suggested in multiple preclinical studies before. And also we had a surprise finding, the gene that I didn't know much about at the time, it's called FAT1. There was some question what pathway it belongs to. Is it belong to the Hippo pathways? Does it belong to the Wnt pathway? It is a gene that is mainly mutated in head and neck cancers. But what we showed here is that indeed the patients who have a complete FAT1 loss, this was a rare variant, but the patients who had a complete FAT1 loss did extremely poorly on CDK4/6 inhibitors. The alterations were also enriched in the metastatic samples compared to the primary tumors. So with that, we try to decipher this better. I show you one of the examples of the patients. So this is a patient who received first-line treatment with palbociclib fulvestrant. And as you can see here on this PET scan, she had a lung nodule, and she had multiple liver nodules and liver lesions. It's one of them here. And she had a relatively rapid progression in the liver, but not in the lung, that actually responded very nicely to treatment after 81 days of treatment with palbociclib fulvestrant. So it's a very short time, short progression-free survival. So we had sequencing data from the pre-treatment sample of the lung and the post-treatment sample from the liver lesion. And what you see here, these are the pileups of the sequencing reads. And as you can see, there is a huge gap on this chromosome 4, the long arm of chromosome 4, where the FAT1 gene is. Indeed, there was a big deletion, resulting in almost all the regions of FAT1 was deleted in this tumor. We also showed that the wild-type copy of the FAT1 was also missed in this liver lesion, and there was not significant difference between these two tumors in lung and the liver tumor, meaning that this is most likely the cause of resistance in that liver lesion. And the work that was done in my colleague's lab, Saraj Chandranapati, it's a postdoc working on the mechanism for more than 2 years, found that actually this is this gene is part of the Hippo pathway in breast cancer, pathway that was significance was completely unknown in breast cancer before this. And we found that there are the mechanism goes through multiple genes, that at the end of the day, these genes result in overexpression of CDK6, and that overexpression of CDK6 overwhelms the CDK4/6 inhibitor. And we have some follow-up work actually showing how this CDK6 overexpression results in resistance. But more importantly, this work resulted in now some development of these YAP and TEAD inhibitors that can be added to the patients who are CDK4/6 resistant and also have and have a Hippo pathway alteration. And we think that we are working on it in the lab to see if this actually improves the outcome. And hopefully, if we see that the outcomes in the animal models and preclinical models are reassuring, then hopefully move forward to clinical trials in this space. Then after this, we started looking at the acquired resistance. We put together a cohort of pre and post treatment samples. We analyzed this data and we found multiple mechanisms of resistance. And what I show here is the RB1 and ESR1 mutations were enriched, something that we were expecting. But also we found that this gene called PTEN was also enriched in the metastatic disease, in the post-CDK4/6 samples, in the CDK4/6 resistance samples. This is a very important gene in the PI3K pathway. Many of you guys know that this is a gene that is part of the approval for the newly approved capivasertib drug, but also results in resistance not only to the CDK4/6 inhibitors, but also to the PI3K inhibitors. So it's an important gene in the biology of breast cancer. We actually started working on the biology of it, but the group by Jeff Ankelman and the Novartis group actually published this work, showing the mechanism by which PTEN results in resistance in this group of patients. So it is an important analysis, an important finding, because it affects the outcomes on the PI3K inhibitors, but also sensitize the tumor cells to capivasertib and this new class of AKT inhibitors and mTOR inhibitors that we have. Then we focused on the patients who do well, but they don't do extremely well. So the patients who are in the middle, they do not achieve the median. So we wanted to see who are these patients, why they don't achieve a long-term response to CDK4/6 inhibitors. Are there other alterations that result in this type of phenotype? And this is another volcano plot that I'm showing, but this one shows the differences in this group compared to outstanding responses, the patients who stay on CDK4/6 inhibitors for years. And as you can see here, 3 genes were significantly enriched in this group. One of them is the gene well known in cancer biology, is p53, is a master regulator. MDM2 has major interactions with p53 and results in an activation of p53, and PPM1D the same. So all 3 genes were exactly part of the same pathway, part of the same node. And that told us that this p53 alterations have importance in that group of patients, but the mechanism is probably different from what we saw in the FAT1 and other resistance mechanisms. Here I show the Kaplan-Meier curves. You see on the top p53 and in the bottom MDM2 amplifications. They all result in resistance to CDK4/6 inhibitors. Those are the red lines. And the work that was done in Sarat's lab with Ray Kudo, who's the postdoc and a breast surgeon in the lab, actually uncovered a very interesting biology, and that is that p53 loss results in the lack of senescence in breast cancer. And there are 2 types of sleeping mode in breast cancer. One of them is senescence, that we believe it's a permanent sleep. This cell goes to the permanent sleep, cannot replicate. That cancer cell is as good as dead. And there is another one called quiescence, when the cell can go back to the cell cycle and start replicating. And we showed through a molecule called p21 and CDK2 that this p53 loss and also MDM2 amplification results in lack of senescence in this group of patients, in these tumors, and then results in resistance. We showed it in preclinical models, and we also showed the mechanism in the lab and also in patient samples. But more importantly, this can potentially provide a window to tackle this mechanism of resistance, but the new class of drugs that are in the development. So that class of drugs are CDK2 inhibitors, because we know that this mechanism converged to CDK2. We think that adding CDK2 inhibitors to CDK4/6 inhibitors in this group of patients might be extremely beneficial. It's something that we showed in the cell lines and animal models, but yet to be shown in clinical trials, ongoing clinical trials of CDK2 inhibitors. So overall, I didn't show you all the data, but we have identified multiple potential mechanisms of resistance to CDK4/6 inhibitors. I would like to call them, some of them, like FAT1 and the Hippo pathway, or some of the growth factors, and to result in hyperactivation of the target, overwhelming the CDK4/6 resistance. Some of them are the loss of target, like the RB1 loss, that result in the loss of the target. So the downstream results in activation of the cell, activation of the pathway, and progression into the replication and cell growth. And then some of them result in the bypass mechanisms, and this p53 and other things, cyclin E, that also interacts with CDK2 seems to be some of them. And then we are now trying to expand this taxonomy of resistance mechanisms in CDK4/6 inhibitors, understand better and understand which group of patients require what type of therapy to better overcome these type of therapies in patients. And more importantly, what I mentioned in the beginning with the endocrine resistance, we would like to do the exact same thing here as well. Try to understand what the tumor is capable of, because what we know from late-stage patients and the sequencing data of the tumors that have multiple resistance mechanisms is that the tumors cannot develop every single mechanism of resistance. They're not capable of developing every single thing. They are capable of 1, 2, maybe a couple of mechanisms, a few mechanisms of resistance, but not all of them. And a lot of it is encoded in their genome, the genes that you are born with as a patient, or a patient is born with, and that's also in the tumor, and also the genes that are mutated in the tumor as unique to that cancer. And those all dictate what type of mechanism this tumor is capable of. And if we know this in advance, we can be, again, one step ahead and try to block this before it happens. And also, more importantly, we can monitor the patients with liquid biopsies to understand the evolution better and try to intercept early. And something that I will touch base on at the end of my talk how we're going to use these combined type of approaches to better treat the patients. So the next part, I would like to talk about some of the work that Anton Safonov, who was a postdoc and a fellow in our group, and now he actually joined faculty at MSK, has done in the lab. This is the work that he came from a background looking at the hereditary breast cancers, and his project was to look at the germline hereditary tumors such as BRCA1, BRCA2, PALB2, CHEK2, so on and so forth, and the somatic mutation, the genes that are unique to that tumor, and trying to understand this interaction better. So we put together a pipeline for the analysis of this type of data, and also we used our clinical genomic pipeline to understand if these alterations have any impact on the outcomes of the patients with breast cancer. So you see another one of those plots, the volcano plots. This is the enrichment in BRCA1. This is well known that P53 mutations are enriched in the BRCA1 mutated tumor. But what was very exciting and interesting to us and was completely unexpected was that in the germline BRCA2 patients, these are the patients who are BRCA2 carriers, P53 was actually not enriched, something that, the previous data based on very small studies suggested that that's the case. It was not the case at all, but it was less common. But what was surprising was that that gene that results in endocrine and CDK4/6 resistance, that RB1 mutation and RB1 loss, was very significantly enriched in the BRCA2 tumors. When we look at the ER-positive, HER2-negative tumors, this even became more significant. And that connection between RB1 and BRCA2 prompted us to look at the outcomes in this group of patients. And here, for the first time, we're showing that the BRCA2 patients are actually doing worse compared to the BRCA2 wild-type patients on CDK4/6 inhibitors. They did almost 2 times as worse than the patients who were germline BRCA2 wild-type. Then we looked at the much larger cohort, this real-world data, as a completely independent our data, to see if we can replicate this finding in an outside validation cohort. And that cohort actually replicated our data exactly with a hazard ratio of 2.0, meaning that the outcomes in this group of patients was 2 times worse than the patients who were wild-type. Then we started thinking why this BRCA2 and RB1 association happens. And what I'm showing here on top is the chromosome 13. And you see that RB1 and BRCA2 are very much relatively close to each other on that gene. And what happens when the patient is born by a germline BRCA2, she has a defective gene, the BRCA2, but there is a good gene, functional BRCA2. So the tumor tried to lose that functional gene so that has a complete BRCA2 loss and become cancerous. So that's part of the pathogenesis of many of these BRCA tumors, BRCA-related tumors. But by doing that, they also lose a copy of RB1 as well. So a good copy, functional copy of RB1 is also lost in this group of patients. I'm showing it here, in this cartoon. You see that RB1 loss and BRCA2 loss happen together. And we analyzed our data and we showed that in the BRCA2, germline BRCA2 carriers, RB1 and BRCA2 almost always were lost together. And very interestingly, around 30% of the patients also didn't have germline BRCA2, but that had co-loss of RB1 and BRCA2, something that we think is very significant in the biology of breast cancer. So that prompted us to think about a hypothesis. And that hypothesis was that if potentially this tumor, because of loss of BRCA2, has already lost 1 copy of RB, then it can lose the second copy of RB with a mutation here shown by this red line. So yellow is a good copy, functional copy, red is a pathogenic copy, something that doesn't work. So tumor can potentially develop a mutation on that good copy, lose the function of RB completely and become resistant. This is, we think, an extension of something that was discovered years ago by Knudsen as part of the 2-hit hypothesis. And in the 2-hit hypothesis, exactly as I just mentioned to you, patient is born with a pathogenic copy of a gene, RB1, BRCA, and then loses 1 copy of it to become cancer. Here, the cancer has lost one copy of it, but has one good copy, develop a mutation to lose that other copy. So we thought that if that's the case, when we look at the pre and post treatment samples in the germline BRCA2, we should be able to see much more RB1 in that group of patients. And that's exactly what we see here. Here, these are the paired samples from the patients before and after CDK4/6 inhibitors. Here you see the germline BRCA2 patients, and the black line around each patient, each column is a patient, and each indicates that was acquired RB1 mutation. So you see that many of the patients had acquired mutations in the germline BRCA2 category, and this was significantly more common in the BRCA2 carriers compared to the wild type carriers, 35% versus 7%. We think this is potentially one of the mechanisms of resistance, and potentially also the loss of BRCA itself also results in the resistance to CDK4/6 inhibitors through other mechanisms, because we see also BRCA1 and maybe some of the other HRD genes can also result in this type of defect. I show here only an example of the two patients that we have. And what I would like to highlight here in these patients is the patient who received CDK4/6 inhibitor, the patient on the left, CDK4/6 inhibitors plus aromatase inhibitor, didn't do really well, then received another treatment and radiation therapy. But then after that, she received olaparib. And as you know, olaparib is a PARP inhibitor. These are designed to exploit the BRCA deficiency in these tumors. And the patients had a fantastic response with a complete response to olaparib while the patient did not do well on CDK4/6 inhibitors. Here on the right, I show another patient who received first-line AI plus CDK4/6 inhibitors, had a progression of disease. Then she received olaparib and had a fantastic response, had some minor progression in the liver for which she received radiation. And ultimately, she had some more progression in the liver. But you can see that these patients had a fantastic response to the PARP inhibitors, but they did relatively poorly to the standard of care first-line treatment, CDK4/6 inhibitors, something that every single patient with breast cancer currently as a standard of care should receive. So that prompted us to design this clinical trial, and I'm very happy to announce it publicly for the first time. This is the EvoPAR Breast-01 phase 3 clinical trial looking at a PARP1 selective inhibitor called saruparib. This is a very potent PARP inhibitor, probably even more potent than olaparib. And we will randomize the patients to receive standard of care CDK4/6 inhibitors, something that we know in this group of patients work, compared to the PARP inhibitor plus endocrine therapy with camizestrant, which is one of those oral SERDs, the drugs that work like elacestrant that is now approved, or fulvestrant. And also we have a third arm with CDK4/6 inhibitor plus camizestrant to compare all of these and see if switch from a CDK4/6 inhibitor to a PARP inhibitor can actually improve the outcome of these patients. And also theoretically, we think these patients potentially can do better after their PARP inhibitor if they receive CDK4/6 inhibitor, because a lot of mechanisms of resistance to PARP inhibitor has something to do with the correction of the HRD and through reversion mutations and other mechanisms. So we think that also can contribute to better outcomes. So this study hopefully will be open soon, and we hope to be able to answer this question in this phase 3 trial. So in the last part of the talk, I would like to deal with something, another way of looking at breast cancer. As I mentioned in the beginning, there is extensive amount of spatial and temporal heterogeneity in breast cancer, something that was suggested by Peter Nobel years ago in his landmark paper. At the time, it looked like science fiction when he wrote the paper, but now it's a reality. And we know that there is extensive heterogeneity in breast cancer. But when we biopsy, we have a selection bias. We go only for the site that we biopsy, and we may miss the heterogeneity coming from other sites. Also, it's not feasible to sequentially biopsy the patients very frequently. We do it very often to understand the biology of breast cancer, to understand the mechanism of resistance, but doing frequent biopsies often is not very feasible. So for that, we started using liquid biopsy. Theoretically, all the tumor sites contribute to the ctDNA pool. You guys are very familiar with the cell-free DNA and liquid biopsy. I was told that this is a very educated group of patients. an advocate, so you know that all the tumors shed some of their ctDNA theoretically into the bloodstream. So potentially with that, we can monitor the disease better, and we can also understand the mechanisms of response and resistance. Something that I would like to highlight is that the ctDNA assays are not the same. There's very significant differences in the way these assays perform, how these assays can be used in clinic, their limits of detection, their capabilities in understanding known mutations versus acquired mutations, so on and so forth. Something that when we use these assays, it is extremely important to understand that these assays are not the same, and each assay has a different threshold and utility in clinic. But the idea here is simple. What I told you, I will try to understand which one of these groups of patients we are looking at. Does the patient has early resistance, intermediate resistance, long-term responders? And there is a group of patients who actually have outstanding responses even to CDK4/6 inhibitors, remain on CDK4/6 inhibitors for years and years and years. So who are these patients? Can we identify this group of patients using ctDNA analyses? And there are two major forms of ctDNA analyses that we use in clinic. One of them is the ctDNA for genotyping. These are the assays that we use in clinic routinely. These are the common liquid biopsies, shows us the mutations. And also more recently, we are using MRD type of a minimal residual disease type of assays that have a better and lower limits of detection. But the idea is simple. Can we monitor breast cancer using liquid biopsy to understand the evolution of cancer and detect mechanism of resistance? And there are multiple works published in this space. I'll show you some of our work. This is a analysis of pre and post-treatment samples from the patients who received alpelisib. At the time we did the analysis, alpelisib was not approved. This is a phase 1, phase 2 clinical trial of alpelisib plus aromatase inhibitors. But you don't need to be a statistician looking at these post-treatment cell-free DNA samples compared to the pre-treatment cell-free DNA samples to see that P10 loss is very much enriched in the post-treatment, indicating that these are mechanisms of resistance when we compare the post versus pre in a single patient. Something that we know, and we have looked at these mechanisms before publishing this work based on just one patient. That this results in bypass of the PI3K alpha inhibition with alpelisib through PI3K beta and other mechanisms. But more importantly, what we showed was that every single patient in the study had some evidence of clonal evolution, with some clones shrinking and some clones expanding. And there were hardly any patient who did not have significant change in the genomic landscape of disease, meaning that each time that we impose a bottleneck, we select for subclones. So the idea is simple. Can we use the ctDNA analyses to identify these diverse mechanisms of resistance, some of which I named in my talk? And if we understand them, can we intercept and improve the outcomes for our patients better? So this is the idea. Can we identify them? If you identify them, can we intercept? And these are the type of clinical trials that we've been designing, and some of them are ongoing in this space. Give the patients, standard of care treatment, see if there is any evidence of molecular progression. If there is certain alteration for which we have a treatment, then escalate the treatment, randomize the patients to be escalated versus not, and then follow the patients for outcomes. And the highlight of this is a study that was done by Dr. Bidard and his colleagues in France, called PADA-1 clinical trial, looking at the patients who received aromatase inhibitors plus palbociclib. They monitored the patients for ESR1 mutations and mechanism of resistance to endocrine therapy and AI. And if they found an ESR1 mutation, they randomized the patients to receive fulvestrant versus continue with AI. And they showed that this approach results in improvement of the outcomes. But the question is, can we go before? Can we understand and intercept even before we have the mechanism of resistance in hand? And the reason is, often it's too late, and the time between identifying the mechanism of resistance and radiographic progression is relatively short. So I told you about the work that we're trying to do based on the tumor baseline genomic characteristics, but can we also utilize ultra-sensitive MRD ctDNA assays to monitor better and improve the outcomes? and also monitor the evolution of the breast cancer. So I would like to give a shout out to Komen for supporting our work and analysis of this type of data using sophisticated ctDNA platforms and genomic platforms that we develop for the analysis of this. So the idea here is to monitor the evolution of breast cancer using ctDNA, serial ctDNA analysis. We can do this in the metastatic setting, and we are doing the proof of concept in the metastatic setting, and we can also move it to the early stage setting. And we can also do multi-regional biopsies and also get the tumor samples from the time of progression and analyze this data to understand which clone is fit and can resist and what that tumor is capable of in terms of developing of mechanism of resistance. So with that, the goal is to try to change the paradigm from where we are now, which is actually fantastic. We find the mechanism of resistance and we try to intercept. But can we go before, when the disease burden in the liquid biopsy is even much below the ctDNA genotyping limits of detection? So this is, I cannot say this tumor has ESR1 mutation or not, because the amount of disease or that subclone that has this mutation is below the threshold. But the amount of ctDNA is actually above the MRD detection. So I can say there is some tumor, and this tumor in the blood is going up. And if I know in advance what this tumor is capable of, then I can intercept much earlier and before this tumor has developed the mechanism of resistance. So that's the idea here for very early interception based on the baseline genomic data of the tumor and also early dynamic changes of ctDNA when we start the treatment. And then the idea is to have adaptive escalation clinical trials in the metastatic setting that can be actually conditioned based on what we know this tumor is capable of. This is my dream clinical trial that hopefully I can do at sometime soon when we have much more data to decipher this better. But the idea is to monitor the patients, find evidence of molecular progression at the time with using MRD assays. Doesn't tell me exactly what's the mechanism of resistance, but I know based on the genomic data what that mechanism of resistance is or potentially is, and then escalate the treatment accordingly based on what we think is the most appropriate treatment for that patient. For example, P53 mutations can be addition of CDK2 inhibitor, as I just showed you, to the CDK4/6 inhibitor to overcome the CDK4/6 resistance in that group of patients. So the FAT1 mutation can be some form of molecule that blocks the Hippo pathway, TYAP type of inhibitors, so on and so forth. We can also think of this as a de-escalation. If we identify the group of patients who are doing extremely well, and also the genomic of the data, and also other clinical characteristics of the tumor tells me that this patient has a potential to be an outstanding responder, we can also de-escalate treatment for those type of patients. They don't need to be on that escalated treatment for a long time. So we can think about a de-escalation. It's not just only escalation, but also de-escalation in the metastatic setting in the group of patients that we know they're going to be outstanding responders. So with that, I would like to conclude and thank you everyone for the attention. And also thank all of my colleagues at MSK who actually made this happen. They do the work, and also my research staff in the translational program, and also in the MSK, at the MSK Biomarker Development Program, and also more importantly, our patients and families that they participated in the studies. They provided us with their valuable samples and data to be able to understand and do the studies that we do, and also our funding sources for supporting our work. Thank you.
Okay, so it's my turn to chime in here and say thank you. That was, first of all, I was kind of smiling through some of it because I worked on some of those studies with you, with the Komen grant, but with some of the other researchers. And I know that my mom's data is in the MSK Impact study. So it's very heartening to be able to have a touch point where it's not just a slide that I'm looking at, but there is a highly personal connection. There's a bunch of questions. I want to start off by just asking you to level set for us the importance of tumor profiling before treatment is started within, you know, once somebody learns, okay, it's no longer just contained to the breast, how important is it to know what you're looking at from
Yeah.
a physician standpoint?
So it really depends on the setting. So obviously, I should mention that in the standard of care setting at this point, at the time of diagnosis, this is not required. So all the approved drugs that we have for targeted therapies based on breast cancer genomics are all in the second line setting. We're talking about alpelisib, elacestrant, capivasertib, so on and so forth. So PARP inhibitors, so on and so forth. But in reality, this is a hugely valuable information because at the time that the patient has progression, obtaining a biopsy, obtaining a liquid biopsy, obtaining a tumor tissue biopsy, sequencing it, these are all time-consuming events and may take, you know, you may do a biopsy and may not have enough tissue, or ctDNA may not have, you know, enough tumor content to be able to give me the information. Having this information in advance as oncologists put us ahead of the game so that we can plan. I try to have plans for my patients that not just for the next line, but for the subsequent lines of therapy based on what I see in the tumor. And this type of information is going to be extremely valuable. So my recommendation is to do tumor profiling with tumor biopsy, tumor sequencing, which is a standard of care at the time of diagnosis, and also with a liquid biopsy that potentially give us more information from some of the other sites that were not captured in that tumor biopsy at the beginning, and also repeat this at the time of biopsy. If the tumor tissue biopsy is not feasible at progression, then the patients can consider liquid biopsy. If tumor biopsy at progression is still feasible, doing a tumor biopsy and also liquid biopsy gives us a much more comprehensive landscape and picture of the tumor. And help us guide the treatment in the next line setting.
Thank you. That's, I'm glad you validated that for everyone, because you know kind of what you're looking at on the inside. It's not one size fits all, because as we saw on those slides, there's a lot, potentially a lot going on, and it would be nice, instead of just kind of, let's throw everything at the wall to see what sticks. You're really being precise and targeted, which is seemingly what's leading to better outcomes here. Okay, so there's a question here about thoughts on treatment vacations to help prevent resistance. Is there evidence for that?
What was the question for sorry, I missed the question.
Vacations from treatment. So pausing treatment, does a pause in treatment potentially lead to a less of a resistance issue?
That's a very, very good question, and something that is being studied in the mathematical models and also in the preclinical models. At this point, there is no information and no data telling us that, you know, removing the pressure from the tumor for a period of time will give that tumor less chances of developing resistance, because there is a competition between sensitive and resistant cells within the tumor. So whoever asked this question is very savvy, understand that these dynamics, and you give the sensitive tumors a little bit more time. But at the end of the day, despite what has been suggested, maybe in some preclinical models and mathematical models, in reality, that has not been the case. And in reality, we would like to keep the pressure on the tumor as much as possible. I think the answer is to escalate. When you see that it's not responding, escalate to another treatment, escalate or add another treatment on top of what we have, if it's clinically appropriate, to try to overcome that resistance in that resistant subclone. Giving the tumor some time to grow, and a lot of them is actually, I should say, it's clinically appropriate for the patients to take treatment holiday. They have toxicity, but scheduled treatment holidays have not been shown to be effective, but something that we should study at some point. And maybe these liquid biopsies can give us some more answers how to design that type of studies in the future.
So you just touched on what the second part of that question was, which was, do you think that switching treatments prior to you observing resistance is helpful? In other words, let's take, you know, we think that maybe well, we know it's going to happen at some point. That's just been the way it's been with metastatic disease.
Yeah.
But the suggestion here is if you kind of like jump ship on this treatment and move to the next one prior to, do you think that would be more
As part of standard of care, no. As part of a clinical trial, yes. I think we should study to see if it's actually as part of a design clinical trial. And I gave you an example of PADA-1 clinical trial. That was a good example, showing that, you know, before the patient had clinical progression, but has a mechanism of resistance with ESR1 mutation, changing from AI to fulvestrant improved the outcomes. It's a proof of concept that this type of study may work, but it's not a one-size-fits-all type of setting, and it's very much depends on the cancer, on the drug, on the genomics of it, and in the setting. So I think in clinical setting, we do not change treatments as long as the patient tolerates it well. So we try to get the most mileage out of every treatment as possible. But as part of a clinical trial to understand if these approaches are appropriate, sure, we need to design those trials, and we have some of them actually designed and ongoing.
So let me ask you this: how do you determine who's a good fit for a clinical trial? And I know we're coming up on time, so but I just to kind of like put a neat little bow on this to dovetail into what you were just saying. How do you, what makes you determine if a patient is a good fit for a clinical trial? Do you wait for the patient to approach you, or do you?
No, actually at MSK, we have a system. As I mentioned to you, all of this genomic data is in the MSK database. So, for example, a PI of the study, the person who's running the study, knows that these particular mutations has a drug that goes after this particular genomic profile, and set up a system for alert at MSK. So whoever with breast cancer that was diagnosed with that particular mutation, the treating oncologists get an email that your patient was just diagnosed, with this particular mutation. We have this clinical trial for, because, well, we have thousands of clinical trials, more than close to 2,000 breast cancer clinical trials, not all for breast cancer, 2,000 open clinical trials at MSK. A lot of them are early drug development, some of them in breast cancer. It's impossible for the clinicians to be up to date with every single trial that is ongoing. So that's one of our ways. We actively also look for the trials for our patients. The patients sometimes come with the ideas and they do their studies and they come. In my mind, everyone is a good candidate for a clinical trial until proven otherwise, if they are willing. And obviously clinical trials are not obligatory. The patients decide, and it's not for everyone to decide to go on a clinical trial, but can potentially provide them with a treatment that can be standard of care many years from now when we run the phase 2, phase 3 clinical trials, or so on and so forth. So I think at this point, it really depends on the setting, the discussion with the oncologist, what are the risks and benefits, considering all of those risks and benefits, and see if it's actually a good fit for them. So the more educated the patient and the oncologist providing the information to the patient, the better the decision they can make. But potentially, I think everyone should at least consider it, and then decide whether they want to do it or not.
Yeah. Okay. So that you made a good point there. Every single drug that we have came out of a clinical trial, and you can't ever overpromise because you don't know what the outcome of the trial is going to be. But if you're taking it today, it's because people did step up and step into a clinical trial. And I know we're at time, so I'm going to tell Casey or Suzanne or whoever is coming on screen to wrap us up. And I'm also going to say there are a lot of questions here, and I am going to step out of my role, and as a personal thing, I'm going to say, Dr. Razavi, we're going to email you a list of questions, and if you could take some time to respond to them, maybe we can put something underneath I'm doing something that I had no authorization to do, but I'm doing it anyway because this is a really important topic. And now I'm going to shut up and let Casey take over. Thank you so much. This was so informative, and I hope the audience got as much out of it as I did. So I'm going to
Thank you for the invitation. Incredible to be here.
Well, we're so grateful to both of you. It was a fascinating talk. I can tell the audience really enjoyed it and was incredibly engaged. I was scrolling through the questions and there was one comment, not a question. So I do want to share it with you guys. It said, thank you for the work that you and your team do each day to help extend the lives of for those of us living with metastatic breast cancer. We appreciate all of you. So I wanted to make sure you heard that direct from the audience today.
Thank you. Thank you.
Thank you so much for attending, Dr. Razavi and Anne-Marie. You were fabulous. I so appreciate your time. Audience, thank you for logging in and sticking here the whole time and asking questions and being so engaged. This session was recorded. I did put this in the chat, but if you missed it, we record all our sessions and they get posted to our landing page and our YouTube channel. So you can reference this back. You can watch it 100 times if you want to get into more of the details. If you feel like you missed something, you can also look at other topics. Like I mentioned, we do a new topic every month. And I did forget to mention this in the chat, but I email it to everyone who registered. So it's going to come directly to your inbox if you're here today. Please help us spread the word. Like I said, we do this every month. So stay in touch, keep up with what topics we're doing, and please join us and engage with us when it feels relevant to your journey. So once again, I just want to say a quick thank you to our sponsors. Our premier sponsors are GE Healthcare, AstraZeneca, Merck, and Gilead. And our signature sponsors are Walgreens and Daiichi Sankyo. So last thing, I swear, and then everybody can relax and enjoy the rest of their day. I mentioned a survey. I'm about to drop it into the chat. And if everyone wouldn't mind just taking a few seconds to fill it out, it's just a couple of questions, and it makes sure that we are delivering quality content that actually is meaningful to you, because this program is for you. So please, 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 I promise I will personally look at them. So lastly, our next MBC Impact Series event will be February 29th. And next month, we're going to focus on metastatic triple-negative breast cancer. And it will be another research update for that subtype. All right, we look forward to having you log in and join. And thank you again for joining us today. This was really fabulous and such a fabulous way to start off the new year. Have a wonderful day, everyone. Thank you so much.
Thank you.
Thank you.